Right, good afternoon, everyone. Thank you, Chair People. My name is Adrian Wong. I'm one of the consultants in Oxford University Hospital, and I think my talk follows on quite nicely from the two talks that you've had before. So I'm going to talk about differentiating causes of respiratory failure using ultrasound. Just by a show of hands, how many of you already do lung ultrasound on a regular basis? I make that to be about 50% of you in the audience, which is much more than I thought I would expect, because we had a much smaller number when I delivered this talk in the UK. So anyway, this is where I work. Very nice. That's Oxford. I always show this picture of my hospital because that's the nicest picture. Where I work on the intensive care unit is actually the basement of this hospital, where it's really dark, there's no natural light, so you might argue that's very good for ultrasound. But I always show these two pictures. It's very nice. If you want to come to visit, you're more than welcome to. Ultrasound, I think, has become more and more prominent because it's become more and more easily available. This is your bog standard, large radiological department ultrasound machine, and they've gotten smaller and smaller. Hands up those of you who've got these sort of things in your unit. Minority. What about these ones? I make that to be the majority, although not quite 50%. Okay, it's been around so much, its usefulness has already been shown, and this was a consensus statement by our own society talking about training standards for critical care ultrasound. I'd like you to note the date, 2010 the meeting happened, 2011 the manuscript got published. So we are now 2017, so 6-7 years on. This has still not transferred to any form of clinical competency statements, guidelines, at least across Europe. Certain countries have already started doing their own thing. So let's take a step back then. A bit of respiratory physiology, causes of respiratory failure. Some people say there are 2, some people say there are 4. For the sake of completeness, I'm going to talk about all 4. Type 1, hypoxic respiratory failure. So that's when your PO2 is low, but your CO2 is normal. Causes: acute pulmonary edema, acute lung injury, contusion, so on and so forth. Type 2 respiratory failure, so this is a low oxygen saturation in conjunction with a high CO2, and there are a couple of causes there. Type 3, which is the one that I think most people may not be aware of, it's the perioperative respiratory failure, which is usually a subset or combination of the other types. But because it is fairly common, it sometimes is put into a category on its own. And finally, type 4, which is secondary to cardiovascular insufficiency or instabilities. I'm going to show you now how ultrasound as an imaging modality will help you identify all these 4 categories of respiratory failure. It's usually a problem with the lung, it could be a problem with the heart, or it could be a combination of both. And like I said, ultrasound, I think, is an excellent imaging modality to help you differentiate the two. We're going to start with the lung causes, if you will. You've already been shown images of lung ultrasound from our previous speaker. And most of you already do lung ultrasound anyway, but I'm just to reiterate the newer people who may not be familiar with. But lung ultrasound in normal lungs is pretty boring. You've got sliding at the top. There are A lines, which are horizontal lines. You may get occasional B lines, which is a horizontal line there. You're allowed 3 per rib space. You get the rib shadows, and that's about it. That's it. Normal lungs, boring. It's true. So let's talk about when things go wrong. When things go wrong, things become interesting, certainly on a lung ultrasound. So let's talk about pneumothorax then. I told you normal lungs have sliding. You can put an M mode, which is an imaging scan, down one side. If you concentrate on the image on the left-hand side first, this is what we call a seashore pattern. So sliding at the top, you put an M mode down the bottom, and you get a seashore appearance, hopefully in a short while. Oops, go back again. Or not. Which is why I hate PowerPoint. Keynote is much better. So let's look at the pathology side, or not. Oh, never mind. This is a very nice image constructed by one of my colleagues for me. So you know that when the lung does go down in the pneumothorax, not all of it necessarily collapses all the way down and moves against the wall. So there are bits of the lung that fall away completely. There are bits of lung that still are up against the chest wall, and there are bits of lung that, depending on whether the patient is in inspiration or expiration, will come and go against the chest wall. And this is what you see depending on where you put your ultrasound probe. So if you put your ultrasound probe in that position, where the lung is intact against the chest wall, you will see lung sliding. When you put the chest probe against the lung where it has collapsed away in the pneumothorax, you won't see any lung sliding. And if you put your probe where the lung is sliding in the respiratory cycle, you get something like this one here. Can I convince you there is a lung margin sliding in? Yeah? Pleural effusions. This is probably people's first introduction to the usefulness of lung ultrasound. Fluid is black. Here are a couple of real-life pictures through a collection I've amassed through the years. That's your lung underneath. That's a large pleural effusion. Again, a similar one. The patient is breathing in this case. You can see how the lung slides into the picture, into the effusion at that point. Don't forget that lung ultrasound is a 2D picture of a 3D structure. Okay? So it beggars belief sometimes when people say to me, I don't use lung ultrasound to put chest drains or intercostal drains in, because you look at that and it's so easy to put a needle into that lung. More complex effusions, you can visualize it directly. These may not be evident on a simple plain radiograph. Look at all the fibrin strands there. Look at that lung that's literally not doing very much. Look at that diaphragm there, which also isn't doing very much. You get to assess these patients in real time. Consolidation, unfortunately you don't, well, fortunately, unfortunately, I'm hopeful that we don't get x-rays such as this one here on the left-hand side very often. We often get chest x-rays that look like that. Someone say, is there increased shadowing? Is there not increased shadowing? I'm not quite sure. But with lung ultrasound, you can see it again in real time. These are all real images. It doesn't take a doctor, an ultrasound expert, to tell you that doesn't look like normal lung. You can see the rim of fluid underneath that, and you can see how the lung moves with the respiratory cycle into the image. More pictures. Often this consolidated lung is often described as having a sick-looking liver in the lung, in the thorax itself. So there's a liver over there, that's consolidated lung, that's consolidated lung, that's consolidated lung. Once you start scanning in your intensive care unit, in your emergency department, you will pick this up much more readily, and they are more frequent than you think. Again, more pictures, sliding in during respiratory cycle. Look at all the punctuates, echo of debris in the lung itself. Remembering that normal lung is boring. It's just a bit of A lines here, maybe B lines, but when pathology happens, it is fairly obvious pathology happens. You showed our previous presenter talked about air bronchograms and how you can spot them. On chest x-ray, air bronchograms are not necessarily the easiest thing to see. But on ultrasound, you can. I've highlighted there. And there is another one there. I'll leave that circle there to show you. But this is a dynamic bedside assessment. You are, as the clinician, are there assessing the patient in front of you, not sent away into the CT scanner away from the bedside. You can do this yourself. So again, the previous presenter has talked about A lines and B lines. Very, very simply, A lines are the horizontal lines, which are reverberation artifacts from the pleura. B lines are the vertical lines that start from the pleura and will slice through B lines. One of my early mentors of lung ultrasound said, B lines are the equivalent of crepitations you hear on chest examination. So again, a reminder, normal lung, boring. I've already shown you this, or it's already been shown earlier. This is the blue protocol. You can just Google it. I've had the privilege of speaking to Daniel Lichtenstein. He has dedicated his entire professional career to developing lung ultrasound. This is his protocol. I'd want to put all the details aside, but look at the diagnosis that you can make if you follow this protocol. Pulmonary edema, pulmonary embolus, pneumonia, COPD, pneumothorax, pneumonia back up there again. I work in the UK. You come from an international audience, but I would hazard a guess that if your patients present short of breath on your intensive care unit or your emergency department, 90% of the time, the diagnosis will be one of these. Again, so let's look at pathology, because that's much more interesting. B-lines, lots of them. That's a dynamic image. You can see it coming in. Lots and lots of vertical lines. You've seen this slide already. It shows you that the sensitivity, specificity are very high for lung ultrasound. These numbers are taken with lung ultrasound being used in conjunction with a clinical history. You will hear, following on from this talk, lung ultrasound in the use of assessment of the movement of the diaphragm. So I'm not going to dwell in too much detail, except to say that we know that one of the causes of type 2 respiratory failure is insufficient neuromuscular weakness, say, for example, paralysis of the diaphragm. You can use lung ultrasound to measure movement in the diaphragm. You can measure the thickness of the diaphragm itself, although I have to say I think that's very, very difficult. Wrapping up the last bit of the talk is let's focus on the heart, because in type 4 respiratory failure, it is due to cardiovascular instability. Lung ultrasound as a modality, like I said, is the only imaging modality that will allow you to do both by the bedside. You don't need a reminder of the types of shock. They're very, very elegantly separated into these causes: hypovolemic, cardiogenic, neurogenic, anaphylactic, septic shock. The characteristic features in terms of their effect on the cardiac output and the cardiovascular system I've listed down on the table on the right-hand side, illustrating, again, a different way of illustrating distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock. But in reality, we see real patients. They do not necessarily fit into nice, tidy categories. Usually there's a degree of overlap between all these categories. And again, using the ultrasound, you can try and piece out which are these categories and which plays the more prominent role in a patient's distress and unwellness. So let's show you a couple of pictures. Tamponade. This is a subcostal view. So right ventricle, right atrium, left ventricle, left atrium. That's the liver edge over there. Can I convince you there's a rim of fluid on that side, pressing against the right ventricle? This is another image. This is given to me by a friend. It was quite dramatic. That's the heart bouncing back and forth in the bag of pericardial effusion, which is the blackness that surrounds these here. More pictures of pericardial effusion. This is what we call a parasternal long axis view. So that's the left ventricle, left atrium, aortic outflow, a right ventricle here, a rim of fluid over there. That's the descending aorta, which will allow you to differentiate between a pericardial effusion and a pleural effusion. And this is illustrated in this picture here, which unfortunately doesn't project very well. But the descending aorta is your marker. Fluid that comes in front of it is pericardial. Fluid that comes behind it is pleural. Cardiogenic shock, which is not uncommon in a critically unwell patient. A couple of loops. Parasternal long axis, parasternal short axis. It doesn't take a doctor to tell you that left ventricle doesn't look like it's moving very much. And on this side, that left ventricle over there, again, doesn't look like it's moving very much. Look at this image. I quite like this image again. So this is a apical 4-chamber view. So you're looking at the heart from the apex. Left atrium, right atrium, left ventricle, right ventricle. Your right ventricular is triangular in shape. Notice the shape of this left ventricle. Bowed over there. Almost in that shape. Takotsubo cardiomyopathy is a well-described, or stress cardiomyopathy is a well-described phenomenon in critically unwell patients. Initially, I think actually we're probably recognizing it more because critical care echocardiography is becoming more and more prominent and easily available, and people are diagnosing this more. It has got long-term sequelae to it. So if a patient has been diagnosed with Takotsubo cardiomyopathy, there is an effect to it. Obstructive, very quickly. RV, bigger than LV, bad. D-shaped septum, bad. So I've shown you lung, I've shown you heart. The power is putting it together together in combination. You will hear protocols such as the RUSH protocol, which assesses the pump, the tank, and the pipes, and they will allow you to differentiate hypovolemic distributive obstructive cardiogenic shock, and also the SESAME protocol, which is again available online. It's a free open access education article. It's by Daniel Lichtenstein again, which allows you to assess and come to a conclusion in terms of why is this patient shocked. So in summary then, ultrasound, I think, complements your skill as a clinician. It's a useful bedside tool. You do not need to send a patient to the CT scanner. But, as already highlighted, it is just a tool. If you don't know what you're doing, you're going to make mistakes and make the wrong diagnosis. And with that, I thank you.
Thank you. Are there questions in the room? Yes, there is one here. Can you give the microphone, please?
Hello, thank you for the talk. I would like to know your opinion about the small devices, if they are, in your view, as reliable as the other big ones. Your opinion about if the small devices are as reliable as the big machines or the big devices, in order to assess both lungs and the heart.
So the question was whether to compare big ultrasound devices, I think,
Yeah,
and little ultrasound devices.
Yeah.
It's to do with image quality, I think. I've tried those portable ones. I think the portable ones are useful because they're portable. So if you're running to a ward, you can bring it with you. The image quality isn't as good as a dedicated ultrasound point-of-care machine, but it allows you to make, is this heart, for example, terrible, or is this okay? But if it's a differentiating 45% ejection fraction versus 55 ejection fraction, I don't think it will do that. But it will tell you that end.
Right. Thank you.
Yes, please, another question.
Yeah, thank you very much for your nice presentation. But don't you think, and you agree with me, that one of the big advantages of using ultrasound in management of respiratory failure patients is to differentiate between cardiogenic and non-cardiogenic pulmonary edema?
So the question is trying to differentiate between cardiogenic and non-cardiogenic pulmonary edema, if I think I've understood your question correctly. I think what people think is that this is the be-all, end-all of it. If you put your ultrasound echo probe on it, it will give you the firm answer. You need to complement it with the clinical examination, clinical history. A patient may have both. A patient may be short of breath because of a combination of both cardiogenic and non-cardiogenic pulmonary edema. With this, you can actually say, I think he's got element of both. Without ultrasound, you may not be able to tell if it's both, if it's one or the other, or a combination. It allows you to separate out those three, I think.
Time for a short question, yeah?
You said the diagnosis of pulmonary embolus. It's just an indirect diagnosis because with the right side enlargement, this is the only way you can tell.
Okay, so the question was using echo ultrasound to talk about pulmonary embolus and right-sided features. So I'm sure all of you are aware in terms of differentiating pulmonary embolus into massive, submassive, and so on and so forth. The crux is hemodynamically instability, isn't it? And hemodynamic damage. How are you going to do that? Yes, you've got BNP, troponin, ECG changes, but actually by the bedside, there in real time, echocardiography is it. So there was a recent case in my own hospital where a patient became short of breath, PE shown on CTPA, and so the question is whether you thrombolize this patient or not. And we did it on the basis of deciding, look at the echo, what did it do? We administered treatment, but because we've got quite readily accessible features to ultrasound, we can then reevaluate what did the right heart do after treatment. Is it getting better? Worse. If it's getting better, good. If it's not getting better, what else are we going to do? And it's real time by the bedside. None of the other modalities, CTPA, you won't send a patient who's short of breath again to a CTPA unless you had to.
We take a last question.
There's a lot of
Thank you for
questions.
your inspiring presentation.